her 30-second delay.
All right.
Video slide.
It's very disheartening when my own equipment at home is possessed, but then when it happens here to him, it's like,
Thanks, Rowan.
turn this on again. Brought to you.
We still have 4 minutes, though, before my arbitrary deadline, so should we just jump the gun here? Okay.
Yes, let's jump.
Because more people are leaving than,
We don't have video on our monitors right now?
I don't, I can listen.
If we have,
We're starting the meeting over entirely, or we're ready to go back into here, so.
We can just pick up where we left off, I think is fine.
I think I am just going to go back where I left off, if that's okay, rather
Yeah.
than going through it. You'll get the slides so you can look at those afterwards, and if you have follow-up
You
questions,
probably
let
should
us know.
introduce that we're back and that there was a delay or issue.
Everybody, public, we're back. This is the Public Health Human Services Board meeting on Tuesday, May 16th, and now it's 8:57 a.m. And we went through just item 1 and 2 on the agenda. We're in our staff report, and we're getting a presentation on public health, mental health, and substance use prevention from Grace Grinager and Andrea Orest and Kristina Manson. Do you think we can get the video on our monitors, though?
The slides,
Yeah.
they're not right now?
No. Should beggars not be choosers?
good response, Andrea, I like that.
Maybe we're not on.
This is a very fragile setup we have.
There we go. Okay,
We are?
thank you. Yes.
No, I mean,
All right,
Thank you, Melissa. That's wonderful.
perfect.
That's all we need.
we're good.
Pictures. Please, Grace, whenever you're ready. I think our technology is ready now.
no signal.
Okay, so these are some of the mental health trends nationally that we talked about, both for adults and for youth. Doesn't advance, so.
This is the Mental Health Advisory Board. Have this presentation yet? No. I'd love to come if you have it.
Okay, I don't know if we will.
I don't know either, but if we do.
Okay. Yeah, okay.
Psych.
I am so leery every time I wake up every morning to know what else is going on in the world. And they blame it, so much of it on this. And I think there's a path somewhere that you need to know about stuff.
Yeah, I don't know why it's not advancing.
That's okay, we're fine.
Well, we've come this far.
We'll lose our
Right.
listening skills.
But if you can
Hey, it did.
It did.
see what's happening in the room, it's something. Oh, wait, maybe
Okay.
it's just a delay.
Is there a long delay?
Like a 20-second delay.
For each side.
Okay, well, we'll just leave it here then and go through the presentation. So this is some of the data from the state, which I spoke to right before we took a pause. So both overdose deaths and deaths due to suicide have increased in the recent past throughout the state. And that's contributed to a decline in life expectancy among Minnesotans. So within Cook County, when we look at suicide rates, we look at a window of time because thankfully we have a small number. So when we look at a window of 5 years, so in this case we're looking at 2015 to 2020, there have been 10 completed suicides reported in the county.
How many, Grace?
10. And when we look at that as a rate, which kind of looks at it as a proportion of the population, it equates to a death rate of 31 per 100,000 during that 5-year period, which is over twice the rate for the state of Minnesota during that same time frame, which is 13.5 per 100,000. So Cook County does have a significantly higher suicide rate than the state of Minnesota overall. When we look at admissions into treatment programs, so in this case, we're looking at a 11-year time period, so 2011 to 2022. We see that the number of admissions fluctuates significantly between 18 and 66 people every year are admitted to treatment programs from Cook County. And it is public data, the primary substance used at admission, which are most commonly alcohol and methamphetamines. So when we look at general mental health data for Cook County, this is self-report data from the Bridge to Health survey, which includes roughly 750 respondents from the county. This is from 2022. We see that just around 20% of adults report a diagnosis of anxiety or panic attacks. Closer to 25% report a diagnosis of depression. Right around 7% report a diagnosis of post-traumatic stress disorder, and just over 5% report an other mental health diagnosis. All right. We'll see if there's a 20-second delay here and it goes to the youth data. So in terms of youth, some of the data that I'm highlighting is related to vaping. And when we look at, this is from the Minnesota Student Survey. So the Minnesota Student Survey surveys students in 5th, 8th, 9th, and 11th grade. So the data that I'm highlighting is from the 8th, 9th, and 11th graders. And we see that when we compare Cook County rates of vaping in those age groups to the state overall, that Cook County does have a larger percentage of youth reporting vaping in the past 30 days than the state of Minnesota overall. And as the age goes up, that discrepancy between the state average and the Cook County percentage grows. So nationally, with the pandemic, there's been a rise in mental health challenges for youth, and that's been well documented through reports by the CDC, by the Surgeon General. When we look at the Minnesota Student Survey, we see that same trend for youth in Cook County. So when there is a report of Cook County students in that 8th, 9th, 11th grade that are reporting long-term behavioral, emotional, or mental health problems. And we see data from 2016, 2019, and 2022, and that just rises in all age groups from 2016 to 2019, and then again from 2019 to 2022. So nationally, mental health challenges for young people are the leading cause of disability and poor life outcomes within the age group, with significant increases in rates of anxiety, depression, and suicidal ideation in recent years.
Grace, while we wait for the slides to catch up, can I ask a question about the data on the adult mental health slide?
Mm-hmm.
I'm wondering if you can contextualize that 25%? How does that compare to the statewide average?
For depression?
Mm-hmm.
It's relatively the same. It's not significantly higher. When you dig in a little bit more, you can see sometimes discrepancies with people living at or below the poverty line and people living above. And you can also see age-related changes. So I'd have to pull them up to see exactly what they are, but you can dig a little bit deeper into the Bridge to Health data set and see some differences within Cook County. But as it relates to the state overall, it's relatively the same.
Thank you, Grace.
Oh, there's the slide I just talked about.
Well, good.
What's that?
Grace,
right.
while we're pausing, I had a question too about
Yeah.
the suicide statistics. So the 10 from 2015 to 2020, those were all Cook County residents. It didn't include like people from other places in the state who,
That's a good question.
yeah.
I don't believe so. I can double check and get back to you. It's through the
Okay.
state's violent injury reporting system that I got the data. And I believe it is by county of residence, but I can confirm that and get back to the group.
Okay, great.
All right.
That is a staggering difference there, the 11th grade statistic for vaping.
Yeah, that's why I was using the mouse before. Oh, okay, there it goes. I think it just takes a couple minutes. So the next image is about the levels of prevention. So within public health, we often focus on prevention. So prevention can mean something called primary prevention, which is efforts that focus on the broad population overall. So this would be things like, for example, the example that will be on the screen is related to opioids. So examples of primary prevention are reducing the need to self-medicate, controlling access to addictive substances, and promoting protective health factors. So there are factors that happen in a person's life that reduce the likelihood that they'll experience a mental illness or an addictive disease. So that could be things like a strong relationship with an adult that cares about them in their life, or building a person's self-confidence. There's a whole list of protective factors that are protective not only against substance use, but also against a whole host of other negative health behaviors and outcomes. It could also look like, from a mental health lens, learning more about the signs of mental illness, being aware of resources for treatment. There's a whole, I don't know, does anyone have any other good examples of primary prevention? That's often where public health will focus its efforts. Secondary prevention is a little bit more targeted. So in terms of opioid use disorders, it could be things like diagnosing and treating addictive and substance use disorders. So it's screening, it's taking away stigma so people feel comfortable seeking out treatment. It's making sure people have access to appropriate treatment and counseling resources. And then finally, there's that kind of tip of the triangle, which is, in the case of opioid and other substance use disorders, preventing life-threatening adverse outcomes like overdose. So this goes into like the naloxone trainings that Andrea has been working on as part of the grant she's involved with. So I think part of what I like about this is it shows that there are multiple levels we can work on, both in the area of mental health awareness, but also in preventing substance use. And I think also when I think about our broad department, it shows that PHHS is really engaged at all levels of intervention and prevention. So we're gonna move into, it worked. Kristina talking a little bit about one of the initiatives that she's taken a lead on, which is the mental health first aid courses that have been in collaboration with the North Shore Healthcare Foundation and Cook County Higher Education.
Hi, this spring we had 2 cohorts of mental health first aid trainings. We had a cohort that was for adults, and then adults for youth. So what is mental health first aid? Let me back up a little bit. Mental health first aid is a skills-based course. Just like CPR would help you assist an individual having a heart attack, mental health first aid helps a first aider assist someone experiencing mental health or substance use-related crisis. In the mental health first aid course, participants learn risk factors and warning signs for mental health and addiction concerns, strategies for how to help an adult in both crisis and non-crisis situations, and where to turn for help, and the importance of self-care for the first aider. So during the courses, participants learned how to apply a mental health first aid action plan in a variety of situations, including when an adult is experiencing panic attacks, suicidal thoughts or behaviors, non-suicidal self-injury, acute psychosis, overdose or withdrawal from alcohol or drug use, or a reaction to a traumatic event. The opportunity to practice through role play scenarios and activities really is one of the ways that mental health first aid feels a little different from my experience from other things, but I only have limited experience in some of those. Andrea has more experience in some of the other options too. There's so many, there's a lot of options, but this is one of them. So also, mental health first aid teaches about recovery and resiliency also. So the belief that individuals experiencing these challenges can and do get better, like Andrea, or like Grace was saying earlier about how mental health is on a spectrum, and how to utilize strengths to stay well. So in a nutshell, mental health first aid teaches us how to identify, understand, and respond to the signs of mental health and substance use challenges among adults. So like I said, when I started, we had 2 cohorts. We had a youth mental health first aid, which teaches adults 18 plus who work with youth how to identify, understand, and respond to changes in mental health and substance use challenges among children and adolescents, ages 12 to 18. And then we had another cohort that was for adults 18 plus to help other adults. So in Cook County, 31 people were trained and certified, 19 youth in the youth, and 12 in the adult. So, and what's next is those 2 cohorts want to continue meeting, and so through the State Health Improvement Partnership, I'm going to help coordinate some of that continued meeting for those groups to continue to practice the skills that they have learned during those trainings. And we hope to bring additional trainings to Cook County and Grand Portage in the future in concert with Andrea and the prevention work that she's doing. So I'll hand it over to you. Yep.
Morning. Good morning. We'll see if the slide catches up. So under the Rural Communities Opioid Response Grant, I work as the prevention coordinator. So the local grantees in that include Cook County Public Health and Human Services, Grand Portage Human Services and Health Services, and then Sawtooth Mountain Clinic. It's a 3-year grant period, and it also involves a larger consortium of agencies that include like the University of Duluth, College of Pharmacy, Johns Hopkins, et cetera, et cetera. It's Harm Reduction Sisters. There's a lot. So under that grant, like I said, I serve as the prevention coordinator, which covers sort of all aspects of that prevention from that pyramid. So primary prevention for youth to prevent them from substance use or misuse. Thank you. And then secondary prevention is that sort of treatment, making sure people have the right connections for like medication-assisted opioid use disorder treatment, recovery resources, and then also that third layer of essentially, keeping people alive. So naloxone trainings, distribution of naloxone, fentanyl test strips, things like that. So the people who are in that category of substance use or misuse, have the resources that they need also. What has been accomplished to date? So aside from collaborating with Kristina and on the mental health first aid. We are working on scheduling more mental health first aid classes here and in Grand Portage. We have done 2 community naloxone trainings in Grand Marais. There was one hosted in Grand Portage. And then we partnered with Higher Ed to do to offer the opportunity to sign up for naloxone trainings in conjunction with their CPR and first aid courses. So if a community member signs up for CPR or first aid, they have the option to attend the naloxone training at no cost. Just to, get more people in the community trained and able to help. Let's see, what else to date? We have talked about substance use prevention, primary prevention. I recently started collaborating with Kristina on her work with the schools on vaping prevention and treatment, and then connecting with a few other youth groups actually today to talk about how I can partner with them for prevention. Let's see, we started a Northern Lights Harm Reduction Coalition that Sue purchased from Harm Reduction Sisters started, so it's a regional-wide coalition instead of just local, so that increases our resources. Let's see, so we have naloxone available to the community via the higher ed courses and also in public health, and Grand Portage Human Services also has naloxone available. Let's see. I'm sure there's more, but we'll go with that for now.
Can I add one, Andrea?
Yeah.
Another project that Andrea's been working on is a deeper dive on the Minnesota Student Survey and better understanding what trends are happening locally with youth as it relates to mental health and substance use. And we're planning to share that with the local mental health advisory council in the near future.
Yeah, and I connected with Kelsey at Higher Ed to set up a community presentation through Higher Ed so people could attend in person and it could be recorded. I'm also working on hopefully presenting on the west end of the county and then up in Grand Portage, but scheduling has become rather difficult at this time of the year, so we'll see how that shakes out. But yeah, so that presentation focuses on youth mental health data as well as substance use data, and then that will be sort of complementary to the work that I'll be doing with Kristina under the SHIP program in the schools, where we'll start with vaping. So the next steps are that presentation on the Minnesota Student Survey data, and then the formation of a coalition, a local coalition to guide the prevention work. Part of the requirement under the grant is that, you know, the prevention work is guided by the community and what the community needs and what the community is ready for. So, you know, I'm in the very early stages of that. I'm hoping that the Minnesota Student Survey presentation, you know, we can use as a sort of jumping off point to invite all sectors of the county, subpopulations, anyone interested in talking about substance use and mental health. I think that's, yeah. Okay, so, related to this, but also, I guess, unrelated, I've been going through some trainings to increase our availability locally for mental health support. So I attended the Applied Suicide Intervention Skills training about a month ago, and that is really just the ability to read people's cues and say, I see these things happening, are you thinking about committing suicide? Or completing suicide, or are you thinking about suicide? And having the skills and abilities to say that out loud in a place, you know, where that person is comfortable and you're comfortable. And that was a lead up to the that was a requirement to attend the Safe Talk Train the Trainer, and that course allows me to do, it's a 4-hour presentation to teach people how to read cues from other people and pick up on, what they might be struggling with, and to sort of offer that warm handoff to somebody who would be a trained in assist or a mental health professional. Let's see, and then in July, I am going to a QPR, Question, Persuade, Refer, Train the Trainer course, so I'll be able to offer that locally too. And most of these will go through higher ed because they have the amazing systems in place to be able to do that. Let's see. We had a psychological first aid course at the Emergency Services Conference, and then also a naloxone training at the Emergency Services Conference, besides the ones that, we had already hosted. And then the mental health first aid, like I mentioned before, we will be expanding that out to offer them more often. So more often and in more accessible locations. And the goal is to create that more localized expertise to provide that ongoing, to provide those ongoing resources so we don't always have to bring somebody in to do those trainings.
I'm still having struggles with the slides. I think, anyway, so what's next overall for mental health and substance misuse prevention? We'll be sharing data and having some community meetings related to the health assessment. So sort of a complement to the work that Andrea's been doing with the Minnesota Student Survey is the overall health assessment. So the draft assessment for this next 5-year cycle will be presented at a community meeting on the 14th. We'll be sending out a link and save the date for a hybrid meeting at the community center. And that'll be open to those who've participated before, those on the mental health and PHHS advisory councils, and also general members of the community. Then as a follow-up, there's a community health improvement plan meeting. So that builds off of the health assessment and is more of a process of the community coming together to prioritize where we want to focus our attention with relation to community health in the next 5 years. So there'll be a lot of opportunities for engagement and community feedback coming up over the summer, both to look at youth health and mental health, as well as overall health, mental health in the Cook County Grand Portage communities. As Andrea mentioned, we are really trying to build that localized capacity to provide continuing opportunities for community members to engage in building skills around mental health awareness and intervention for substance misuse, for suicide. We really just want these opportunities to become as accessible and mainstream as CPR first aid. We want everyone to be able to have access to them, and it's much easier to build that access when we have a pool of localized resources that has the training and expertise to provide that to others in the community. And then, as Andrea mentioned, that partnership and coalition building. So quite a bit of what we do in public health is done in partners with others in the community. So Andrea spoke a bit to the coalition that's formed around that RCorp grant for opioid work and substance misuse prevention work overall, but really the work Kristina does is entirely focused on coalitions and partnerships, and I would say that's kind of common to even the health assessment, health improvement plan. We really try to bring people in and get feedback from a large segment of the population so that we can be as responsive as possible to what people's needs are and really build off one another's strengths and capacity. So that's where things stand right now, and that's kind of our roadmap moving forward. Happy to take questions, make sure everyone gets a copy of the slideshow, and then I'll make sure I get back to you all with the answer to that question about suicide data as well.
Thank you. I bet you we got questions. Please,
right.
Commissioner White.
When you talk about vaping, that's just what you like, go to Holiday and you buy tobacco replacement cartridges, is that talking about putting hash or marijuana or something into some sort of a vaping vial or however? I've never even, I don't think, seen one up close, so I don't.
So you can buy them pre-filled at the gas station, or you can actually buy them to fill yourself. I don't know.
And so what is the issue with our students? What are they vaping with? The pre-filled, the pre-filled, or are they putting something more exciting in it?
Both.
Oh, okay.
It's, when we look at that, the data on vaping, it's an inclusive term, so it could be either or, and it primarily includes nicotine, but it could include other substances as well.
Yeah, the student survey actually breaks it out between nicotine and THC. Those are the two options that you can, on the student survey. And there is both locally, but the nicotine vaping is much higher than the THC. But based on conversations, it seems to be that the THC use is growing through electronic cigarettes, which is vaping.
Any other questions here? Commissioner Hawkins, please.
I'm wondering about the 31 individuals that were trained in the mental health first aid and who they are training for. Are these part of their jobs, like teachers, or are these just individuals that have mental health issues in their families?
It's a combination of both. For the people who are trained in the adult mental health first aid, I noticed a lot more community members in that class, but it was really honestly a 50-50 mix. With the youth mental health first aid training, we did see quite a few staff from Cook County Schools and GES there too. But that was a larger cohort too. So I feel like it's a yes and both. Yeah.
Wondering how they're going to use those skills they learned. Where is it going to be applied?
Would you mind, Kristina, speaking to the goal of having a certain percentage of educators participate in that cohort and how that relates to incorporating the content in ongoing school-based training?
Right. So for the youth mental health first aid, there's an opportunity there's another type of mental health first aid called teen mental health first aid, which is intended to be integrated into a school. And for that to even be an option, a school has to meet a certain threshold of capacity of teachers trained in youth mental health first aid or staff, and that threshold is 10%. And so we did get, if it's just staff that needs to be trained, we did get very close to that 10% threshold. And we are exploring options for a comprehensive mental health plan for the schools and looking at different options. However, several educators and administrative staff were at the youth mental health first aid and feel that they're really seriously exploring the opportunity and option of potentially integrating teen mental health first aid and the Cook County High School. And I can talk more about what that looks like if you'd like, but this is all in the very early planning stages, so I don't want to put the cart before the horse, but yeah, no problem.
Please, Commissioner White.
Kristina, so was this training offered to the staff up in Grand Portage also? I mean, did you take the training up to Human Services up there or for the adult mental health training and/or then the youth mental health? Was there any interest coming from that community?
So these two trainings that we offered this spring were conducted at Cook County Higher Ed. We did have participants from Grand Portage, and there is very high interest in bringing these trainings to Grand Portage.
High interest from whom? From them? And if from us, why don't we have it there?
Yeah, so as part of the prevention grant includes bringing mental health first aid to Grand Marais and Grand Portage. Grand Portage Human Services is working on scheduling their own under a different grant right now. So we will partner with them to help, with any resources that other grant doesn't cover. And then also, like I said, we'll be able to offer it more often in more locations, so that would be Grand Marais and Grand Portage.
Because I know that their resources it would make sense to take them to Grand Portage when possible, or Zooming, because they have 4 people. And I know last week or the week before, they had, what did they say? 4 attempted suicides of, it was adult males, but, so they're a little stretched a little thin to be able to take time out and to come down here for training, so.
Right. We work collaboratively quite closely with Grand Portage Human Services and Grand Portage Health Services, so anything that we plan, we plan together with them to create as much location equity, I guess, as possible. So there's more to come.
Okay.
Commissioner Storlie, please.
Thank you, and thank you for doing this for our little county here in Minnesota. I attend a larger organization called NACO, National Association of Counties, and the first week of May, we all talked about how we're going to do mental health awareness in the various aspects of the United States, and they came up with, they start with high schoolers, then they're going to talk to senior center, because a lot of the seniors have grandchildren that they're concerned about, so it was a variety but it was a good conversation. So be aware, it's all over the United States being discussed. Not just May, but that's the awareness. Thank you.
Thank you, Commissioner Storlie. Any other questions?
I'd just like to share a comment. I had an opportunity to attend the naloxone training at the Emergency Services Conference, and it was very, very well done. The information was very well received, and I now have 2 doses in my first aid kit, and I appreciate all that you've done to help our community gain the skills that they need.
You're here.
Andrea, while we were talking, found the answer to James's question about the suicide rates. So it is by the county where the injury occurred. So it's not necessarily Cook County residents.
Okay.
And I'm not sure if I can take that data out of here or not. It might just be by the county where the death occurred.
Yeah, that's an important distinction, because we know that people actually come to Cook County for that purpose, which is tragic, but it happens. So just wanted to get a handle on how that actually looks. Thank you.
One of the things that stuck out me with prevention is that for youth, having an adult that they feel close and comfortable with, or have a relationship with. And there's an individual, and there's many individuals in our community, but there was an individual in our community that I specifically thanked, because I noticed their relationship with seemingly random youth, both at like the dance recital as well as the Y, and just said, hey, thank you for being that role model and developing those relationships, because it makes a big difference in a kid's life to have that kind of the cool adult or whatever, and so whether that be coaches at sports or any other after school curriculum activities, the playhouse or any other relationship we can foster in our community with youth, I think is really helpful, just to have that connection and that kind of safe place. And that's something that we can all do, one of those steps, without training even. So,
right.
But
yeah,
an important, please, Andrea. No.
Well, I was just going to say a big piece of prevention really is promoting and building up protective factors and breaking down risk factors. So having meaningful relationships with adults in your community and at your school and in your family, and, you know, having those, I mean, there's a whole list of things that, you know, build up protective factors that help with prevention. So if you have, the more protective factors you have, the less likely you would be to use substances or have, yeah. So that's a good point. And part of the work that I'll be doing in a little bit will be meeting with youth groups to talk about, you know, increasing those protective factors and how we can collaborate and help support those.
Thank you.
Yeah.
Any other questions, comments? Please,
Well, I'd like to
Commissioner
just throw in about adult mental health, because I heard some little quip someplace in the passing through life. But, again, and we all know this, you never know what's going on in anybody's life, strangers or not. So those little random acts of a smile might be what really saves a person's day, you know. So everybody has a need for kindness.
Yeah.
Well, you don't have to go so far and be really kind, but you can be passively kind by not sneering at them.
Not too kind.
Yeah, we just like, I acknowledge you are there. Yes. So which gives you value.
Absolutely, absolutely. I agree. The other, actually, that reminded me of a question too, just about, often when I'm talking with people in our community about mental health and mental illness, there's a perception out there that there's a broadening of criteria. And I don't know if there's any truth to that. I know there's a lot more awareness around it and a lot more, I mean, we're discovering things every day. There's cognitive science degrees being, you know, where the mind meets the body sort of thing. Like that's a newish field. So do you guys know anything about that? Like, I can't imagine the criteria has broadened. Like it's pretty, or whatever, I don't know.
I wouldn't, I don't know specifically about the criteria broadening, but I do know that with the pandemic, there was a huge rise in social isolation, and
Yeah.
that's one of the major contributing factors to poor mental health
Yeah.
and some of the associated struggles that go along with that. So, and it's persisted beyond the more acute phases of the pandemic. I think there are lots of factors that they associate with that social isolation: living far from family and friends, using more social media, just having a more, getting into patterns that don't build that connection in day-to-day life. But that's, there was actually a Surgeon General report that came out
Yeah.
last week,
Yeah.
calling it an epidemic of social isolation that they very strongly tie to poor mental health in society at large. So, yeah, in terms of the specific criteria to diagnose, I don't believe that that's changed, but I do think there are some external factors in the world that play into people's experiences.
Yeah. Well, and even it was interesting to see the data from 2016 to 2019. That's before COVID, and just that stark increase. It's not before social media, though, interestingly enough. So it's just absolutely, so, the pandemic had a huge impact, but it's interesting to see that even before that, there was this trend happening, so.
And to speak to diagnostic criteria, I know that the DMS 4 or 5, you know, those ones are constantly being evaluated, and it may be a more appropriate question to maybe ask a practitioner who utilizes those criteria and could maybe speak to some of those processes of how things are being broadened or different ways of looking through those criteria for diagnosis.
Well put, yeah, good point. Yeah.
Also say
Unfair question.
I'm just, if you're
Yeah, no.
answer that
Yeah.
they might be they might be able to speak to that more in depth for you.
Yeah, thank you.
And digging into some of the youth data, specifically from the CDC, they do show rates of suicidal ideation and depression significantly higher for girls and for members of the LGBT community. So you can see these population trends, and then you can dig in and see some real differences in how different groups experience things like depression in terms
Yeah.
of.
Thank you. All right. Well, I think we can let you get on with your day, and thank you for the presentation, and look forward to the slides.
Thank you.
Yeah.
Thank you.
Have a
Thank you
good
so
one.
much.
And I believe that brings us down to Allison.
Indeed. Well, I will echo the thanks for our resilient and prepared public health team rolling with the unexpected challenges of presentation logistics today. So thank you all for your work to pull this information together, really important information for our board and community to hear, and the excellent update on how you're engaging more deeply in this work going forward. So thank you all. I'll start with a staff update. In the agenda materials, I included an updated organizational chart to reflect our current staffing, including our now 3 vacant positions in the department. I'll summarize our work to fill those positions now. First update being that we had offered and this board had approved the hire of a family services case manager candidate working in child protection, child welfare, and some other more prevention-oriented parent support programs. That individual unfortunately had to withdraw from the position, so we are now actively recruiting again for that family services case manager position. We have an interview scheduled, and we have also posted for a temporary case aide position. Given the fact that this position has now been vacant for almost a year, this is a considerable amount of pressure on our staff who are currently covering that caseload. It's has the potential to impact families in terms of the level of service they can receive when we are short-staffed on that team. So we are looking both to fill that permanent, full-time case manager position, and we are looking for a temporary open to part-time case aide to provide some immediate support with things like transports, helping families complete paperwork, things more hands-on in the community type work to provide support to families that we're actively working with. We are interviewing for adult mental health case manager. We had an interview last week and are making an offer for that position. We have reposted the coordinated mental health crisis response worker position that's now posted on our website. And then finally, my last staffing update, on a preview of what we have under items for board action today, and that is increasing the hours for our public health educator, Kristina Matson, by 10 hours, and this is a grant-funded regional position that I gave an overview of at our meeting last month to provide lactation support, very much well aligned with the statewide health improvement partnership grant that Kristina is currently working under in supporting policy systems and environmental change in health systems, workplaces, and at a community level. So I'll pause there after my staffing updates. Happy to take any questions on the updates or the item for board action.
I just want to thank you for the org chart. I just love this. It's so helpful, so thank you.
Hopefully we'll keep that in the, put it in the appendix of our board packets or something.
Have that be
Yeah.
a standing.
Yeah,
Yeah, it's great.
thank you. Question? Oh, please, Commissioner Hawkins, I'm sorry.
So I'm curious about the crisis response position.
Yes.
Is this person going to actually be out in the field doing the work?
Thank you for your question, Commissioner Hawkins. We did post the position without any changes to the job description, so that does include the co-response, community-oriented work, partnering with law enforcement, Grand Portage Human Services staff, our own social work staff, and hospital staff to help individuals in crisis navigate those systems. So yes. Does
So it will be
include-
different than the last coordinated person in that job? Because that person did not do any field work. I just want to be clear of what we are rehiring for.
Yes, yes, we are rehiring for a person to provide that in-person response. In addition, we are also building a team within our department of social work staff who have additional training and experience to provide that daytime crisis responses. We can't expect one individual alone to do this work, and we need to have a backup system in place. So our social work staff are developing that system right now for backup response to be that designated daytime crisis responder when we receive calls referred from the regional crisis line.
And I was under the impression from our committee of the whole discussion when we had the report, just that there is still, and as you said, that our staff are developing that system, but there is still a significant amount of work to be done with developing that. It's not just a turnkey system that we can ready go. And to Commissioner Hawkins' point, is that how much of that development would be expected from the crisis response worker versus kind of the team that's working on it? I mean, maybe that's not fair to quantify it like that, but just I think that's getting to your concern, right? Just that there was kind of that system to be.
We had somebody in the job for 6 months that didn't actually ever do the job yet. We talked about how to do the job, and I want to make sure if we're rehiring for this job, it actually gets done this time, put into motion, that we see whether or not this is effective. But that brings up my next question, because we had it, this was a grant-funded trial program for it. So where are we at with grant funding for continuing this position?
Yes, so the pilot is funded for 2 years using the county's ARPA allocation, the Federal American Rescue Plan dollars, and we were also able to secure additional crisis grant dollars through our regional Arrowhead Behavioral Health Initiative. Because it took almost 10 months to fill the position in 2022, and was only filled for 6 months total into 2023. We are underspent, and we expect to be able to continue to fund this position through 2024 and seek out additional grant dollars to sustain this position. A part of this work will also be working with our local partners as well. The expectation is that having someone in this role, having a more efficient, coordinated response system, because our staff alone cannot, act as the crisis responder within a law enforcement context, within a hospital context. There needs to be matching expectations, clear protocols in place about transitions of care. So we expect to work with our local partners, access regional crisis dollars to continue to support this position going forward.
Commissioner White, please.
So, the last person in this position, working on creating the process, long time. What happens in between? I mean, what happened before this position? I mean, we've got a crisis and we don't have a coordinated effort. We just have a bunch of people who are all capable of doing much of the same crisis intervention. Or, I mean, if there's a crisis, somebody's got to be right there and do what they can till professionals can come in. What happened before there was this position? I mean, how did this county manage to help people in crisis before there was a process in place?
I think
Depends on how far back in history you'd like to go.
Let's go 3 years.
3 years ago? Okay, so around 3 years ago, at that point, the Human Development Center office was closed. We did not have a designated crisis response system. I believe 3 years ago, correct me if I'm wrong here, Commissioner Mills, but that was when Birch Tree Center and Thrive were a regional crisis provider. This was prior to First Call for Help taking over the regional grant for crisis response.
Mhm.
So at that point, And to this day, an individual in crisis could present in a number of different ways. It might be a family member with a concern. It might be an interaction with law enforcement. It might be a medical interaction. Every situation will be different depending on how that person presents and what entity they're interacting with. That's what makes this work so complicated, is that there's no one pathway for crisis response services. This is not unique to Cook County. This is a systemic issue across the state, across the nation, because of the lack of funding and coordination for crisis response services. The State Department of Human Services recently released a study that I'd be happy to share with you all that goes into some detail on crisis services statewide and the many deficits and gaps there. So we are not alone in having a very fragmented crisis response system. And a lot of what's contributing to that is that the various systems involved have all very different statutory responsibilities, roles, views on how to interact with a crisis, whether it's from a human services standpoint, from a medical standpoint, law enforcement, or a friend or family member attempting to assist that individual. So our approach through this coordinated crisis response pilot has been to better understand what is happening now when people are facing crisis. That was a lot of Matthew's work in the first 6 months of their position, conducting after-action reviews, interviewing dispatchers, interviewing emergency service personnel, interviewing human services staff at the tribe and at the county. How are you currently supporting people accessing the mental health system? Reviewing what happened, debriefing real life situations when people were experiencing crisis, what went well and what didn't. So I don't know that there's one answer to how things were before, because it was situationally different depending on the individual's experience and how they were interacting with different health, legal, social services systems.
I would answer that as just not in a fully coordinated way, right? Sometimes it would be just law enforcement who maybe didn't have the training, and maybe there wouldn't be enough perceived harm for law enforcement to do anything, or sometimes maybe there was, and then law enforcement would bring them in or whatever, and then if the hospital, speaking of law enforcement, and then if the hospital was involved, sometimes there's enough symptoms or things that they can identify or not, and so it was. I think it's suffice to say disjointed, or maybe not as coordinated as can be effective. But
So to that point, I mean, maybe it's a totally wrong assumption I have in a small community, but that our agencies that are here for the public good, are they prohibited from sharing some information or to reach out to other agencies and say, we have an issue that I think might be, we have a community member in need, but it's beyond, can they tell? I mean, like, say law enforcement is aware of something in a household that they're called to for whatever reason, for some law reason. Do they then have the legal right to then contact Public Health and Human Services and say, I really believe this family needs some intervention? I mean, is it a legal issue? And then my assumption is they do that. Or is that wrong? Wrong
So
assumption.
we might receive a referral from law enforcement after an individual has a crisis experience. Data sharing, transitions of care at a point that a person has completed their interaction with law enforcement or is being discharged from the emergency room in a behavioral health crisis. That's really one of the core issues that we're working to sort out in this pilot, is how can we work more effectively at those transitions of care? How can we exchange information to better support people in terms of aftercare and crisis support planning? We met on Friday, myself, our behavioral health supervisor, John Speaker, Jackie from Grand Portage, Sheriff Eliason, and Kimber from the hospital to do kind of a reset on the pilot. Where are we at? Where have we been? How do we keep this momentum going during our staffing transition? And that was one of the primary topics that came up, is how can we have some shared understanding about how we exchange information? How can we ensure that people in crisis, if they aren't already connected with human services, either at the tribe or at the county, receive that referral? And how can our staff help support them with ongoing safety planning? So it's something we're actively working towards.
And so is it legal for the agencies to share information with the permission of, I mean, I'm not talking children per se, but an adult has a need beyond legal law enforcement, or they have a mental health crisis or a medical thing. Can those agencies legally maybe not share specifics, but to say, definitely, we think that this person needs to have services from your agency? Can they legally talk to each other without breaking confidentiality of your patient?
We might need a LIA for that.
I think with a signed release or with a referral, with the permission of the individual involved, that information could be shared, but I'm hesitant to give.
So that would interfere with a process, that if a process doesn't exist, then that would be could slow help down if you don't have that in place?
It could, absolutely, because our, crisis response services are voluntary.
Oh, yeah, right.
Can I say?
Oh, I'm sorry, please.
We're talking about 24/7, 7 days a
Yes.
week, and so one person can't possibly address every single situation because they would never sleep.
No.
That you have to have multiple people working, and every person may handle things just slightly differently too, which is fine, but it's hard to give a blanket coverage for that because that's not how it is. And I know we talked about, too, that the doctors at the emergency room aren't the same all the time either because they rotate and they're not local. And so there's just a lot of moving parts to keep track of, to keep consistent,
Okay.
Every situation's really unique in that way, I would say.
And Rana, thank you for your comment, because I should also mention that we do have a separate process for after hours and weekends, which is our regional crisis response, which is staffed by the Human Development Center. They're local people in our community who are employees of Human Development Center, providing that after hours and weekend crisis response. So another complexity to this work is another entity involved.
I thought
but
they
in
were all
terms of-
gone. That's great.
No, it's like an on-call,
Yes.
contracted thing, so the presence is, we don't have HDC here like we did, but there are still contracted. I think I've known a couple, but.
But in terms of the designated entity to provide daytime crisis response, that role has fallen to Public Health and Human Services informally since HDC closed, and we haven't had a consistent process or protocol in place for responding to those. Those have come through our social services intake system, and we have very skilled and talented social workers on staff, but not all of them have specific training in crisis response protocols. So that, alongside the coordinated response pilot, has been the focus of our efforts to strengthen that system in the daytime hours.
Basically.
And as you mentioned, Commissioner White, Grand Portage Human Services have their own system for responding to crisis response as well. And we've been working to complement and support that system as well.
Yeah, we've basically been trying to build the system after HDC has left,
Right.
And it hadn't been Public Health Human Services' role in the past, and so kind of creating this and seeing how it would best work and what best fits and what are the challenges and obstacles as part of that pilot program, so. Step by step, but I see we lost our public health reps there for timing wise. Are there other agency updates, or are there other questions from commissioners before we get to items for board action?
I have a few more agency updates I can run through very quickly.
Okay.
I want to first give kudos to our adult and home and community-based services team. They recently completed an audit through Blue Cross Blue Shield one of the managed care companies that our staff, social workers, provide care coordination to enrolled members, and we received 100% compliance on our recent audit. So congratulations to that team for their excellent work, documentation, and service to members. A media release went out last week regarding the end of the public health emergency and how that changes our the way we're sharing information about COVID publicly. We've discontinued those case count updates every week. The CDC is also changing how they report out information. So if you have yet to see that, it's posted on our county website. We are also reconvening members of our Public Health and Human Services Advisory Council Public Health Fund Review Subcommittee to discuss our timeline and process for the 2024 Public Health Fund. Grace and I met with Chair Sullivan and Administrator Yorkie last week to talk about how that grant-making process intersects with the countywide discussion underway regarding non-mandated levies and discretionary funding. Our plan is to bring back the subcommittee this week. We have 2 meetings scheduled to bring that group of busy individuals together to both review the 2022 year-end reports from grantees, discuss the request for proposal for 2024, and a timeline for reviewing proposals. We will be using the existing community health assessment and health improvement plan to guide our strategic priorities for grant making again this year, because as you heard this morning from Grace and the team, we're just in the process of updating that for the next 5-year period, that being the community health assessment and health improvement plan. Grace mentioned our community health assessment meeting at the community center on June 14th. And June 13th will be that process of engaging in the prioritization with community members and providers. Also want to give a brief heads up that our plan is to present at the July Committee of the Whole on the various child care initiatives, including the provider wage enhancement program that we've been piloting for the last 5 months. And I think that's it from me, unless there are any questions.
Any questions? All right. Well, that moves us on down to items for board action. Here we have the public health educator, as previously discussed here. Is there more you wanted to say on that, Allison, or does anyone have any questions about that?
I have a question, I have a concern.
Okay, please.
Again, because I do this with other positions that are funded by a grant, I can't support increasing hours for our county for a regional grant. I mean, 7-county region, we're the smallest county. But we're going to add it to our list of to-do items. And I think it should be designated more as a contract. If we decide, okay, we have the capacity to take this on, do it as a contract and clearly state that this is only if we get the funding from the Community Health Board or whoever's funding this position for this. And then, when that grant runs out, we evaluate, is this a good fit for Cook County, or should some other county take it on?
Yeah, I think the reason why it was looked at for Kristina's position, for that SHIP position, was because other counties were kind of polled looking for that fit, and my understanding was this was basically the easiest fit, and
because we never say no. Yes, I get it. This was a contract position.
Excuse me, I wasn't done, but that's one way of looking at it, that we never say no. But the other way is that we have a strong public health team. We have a part-time position, and we're trying to really do this regional system, right? Like it's not, we're trying not to isolate Cook County just as, and we use Carleton County for some services. We certainly use St. Louis County as well, and then we certainly use Lake County as partnerships too. So it's just another example of the partnership, and in this case, what the region was saying is that it fits best with Cook County, but you are free to vote against it.
Thank you.
I'm confused by what you just said, Stacey, so you have to help me with this.
Yes.
I think we've just gone through a presentation that shows the need for education here more than ever. And that's what the increase in this position would do. So where am I confused with what you just said?
The increase for this position is for the regional lactation support role, which provides technical assistance and support to regional breastfeeding systems, as well as the 7-county Healthy Northland SHIP group. So my issue is, this is providing regional labor and delivery postpartum unit nursing staff at hospitals to support baby-friendly initiatives. Totally think it's a great idea.
Right.
We don't even deliver babies here. So what I'm saying is we are adding hours to our staff that potentially I could see going on forever to provide regional support. And I'm thinking, if the other regions really think this is, that they have lots of babies born in their counties, how come they're not stepping up saying, yes, this is important, we need to provide this? But us, the smallest county, without even a hospital that will deliver a baby, we're asked to be the one to do it and put it on our levy.
Oh, I think this is a grant.
Right.
Which goes back to me saying, other counties, the way they handle this is they use it as a contract saying this position is grant funded, and when the funding is no longer there, we reevaluate this position. We know we've had positions in the past that have started that way and then continue on when that grant funding has run out. We don't have a mechanism to reevaluate that.
I don't know what position you're talking about for it ran out and then we continued it. I think that's one of your common fears, but I don't know the position that's happened to yet.
No, I'm not going to discuss personal people here now. But yes, we have in the past.
Can you just say the position?
Well, no, I can't. I'm sorry. Right now, I can't say.
I think that is a concern you bring up.
Yes.
And I have heard the concern before, I just haven't seen it materialize yet. And so I want to make sure that we're talking about the different funding, because it's not levy funding, it is grant funding.
And so the question I have is, why wouldn't that become a part of a conversation when the grant is ended anyway, to become that next position? Isn't there a conversation where that happens, Stacey, where we have to have that conversation to make it a permanent staff position?
It would happen here, yeah.
Yeah, so I'm sorry.
We are increasing the hours for this position.
Right.
Yes.
I think.
I don't
Isn't
see a
this-
date
Well,
timeline.
I thought you say we don't have babies here. I think that's the reason to have this position, because people don't have that relationship with a staff person locally. And they just come home, they had the baby somewhere else. They need support. And I don't think this person's going to be traveling the whole area. It's for our local people's support.
Well,
Even though it's sponsored by that, but isn't it right, Allison?
well,
The
to be
people here?
clear, this is basically training the systems, right? So, the position would not be going to the individuals who don't have that support. It's more of that system-wide training. There will be some travel, but I think a lot of it's done virtual. But please go ahead, you know better.
We're just going to make a few comments. First, to your point, Commissioner Hawkins, about, why are we being asked to take this on and not any other county in the region or our regional community health board, and that conversation has already taken place at a regional level to determine capacity, interest, and ability to take this on. So our Susan Michaels, who is our community health board director, each of the local public health departments represented in our community health board have been a part of these conversations to determine what's the best fit for this discrete regional position. As it relates to grant funding for our public health positions, nearly all of our public health positions are grant funded. And any time that we have a grant period ending, we're, as you said, reevaluating. What are there other funding opportunities? Are there other areas within our 5-year community health improvement and health assessment of those strategic priorities that our community has defined for health improvement, where we can seek out additional grant dollars to support our staff time and to increase our capacity to do this health improvement work within the community and region.
So this increase would not be an outlier as far as how a lot of public health business is done, is that, as far as the grant funding is concerned, right? Like you said, nearly all are grant funded.
Nearly all of our positions are supported with grants like this that come through the State Department of Health through our Regional Community Health Board to offset the cost and the levy impact of our staff doing this work. They're all working under grants.
And if the grant funding runs out, then we will be having further discussions, as Commissioner Hawkins, I think we were saying we should be having, and we would be having. So, Commissioner Storlie.
So the grant funding is for a period of time. If we increase the number of hours and wages, the grant will run out faster. Then we're back reevaluating. Is that the way it's going to go?
So this is a separate grant allocation for the time period. If you look at page 13 of your agenda, this has the breakdown of our budget revision. We carried over some funds from the last grant period due to the turnover in the SHIP coordinator position and transition from Sawtooth Mountain Clinic to the county.
So 54,872 is available right now.
That's the current approved budget with the State Department of Health for the SHIP position. We've submitted a budget revision, including these additional funds to support that regional role, and are awaiting MDH approval, but would expect that.
Commissioner White, please.
So, Mike, back to Commissioner Storlie's question, does that then, it increases the outlay, and so does that reduce the amount of time that the dollars are available? And then it would run out sooner for an evaluation would be needed?
No, because these are additional grant dollars dedicated to this regional lactation support position that are being incorporated in our SHIP budget, the Statewide Health Improvement Partnership.
So if I just understood what you said, Allison, if the funds do not come in, this position would not exist, right? This additional position.
The regional lactation board.
Right. You're assuming the funds will come in. If they don't come in, then what will happen? I'll ask the question that way.
Then we would reevaluate other funding sources at a regional or state level to support this position, whether this position still makes sense to be
Makes
housed
sense.
within the Public Health and Human Services Department. Are there other grant opportunities that we could pursue to continue this work, or if not under this grant, in another fashion? Or would this be the time to ask the CHB to reevaluate staffing the role within their structure or within another county in the region?
Yeah, that's what I was going to say, is if there wasn't grant funding available, then, just like Commissioner Hawkins was saying, why would it fall on Cook County to provide this regional position? That totally makes sense to me. But while there's grant funding, then I just see it as just a way to collaborate, so.
Does that mean then that we would reduce Kristina's hours back to the amount, or we would continue on with her hours being increased?
Well,
That's what I'm not understanding how that works.
So that's, the increase in hours are tied to the grant, and so if we didn't get the grant, then we would have a conversation, and it would seem to make sense that they would be reduced, because it's not Cook County's responsibility to carry this position.
And then how do you contractually write that? I mean, is she under I don't know what union she's with, but would she be stepping out of the you don't play favorites with employees when you're part of a union contract. And so if you were, how do you give somebody an additional 10 hours a week?
With funding, with grant funding that's tied to it.
And you have to.
And when the grant funding's taken away, then you
And that'll
take
be
that.
in writing somewhere.
Yeah, I think,
There's no financial obligation to continue those hours beyond.
And that'll be in
the
writing somewhere.
it always is. All of our grants are through this, I mean, this is through the state. This is like state funding, regional funding, it's all,
But the question I really did have, though, what other agencies and groups in this county already help with help mothers, new mothers, mothers-to-be? We have a number of midwives, we have a number, I don't know what they are, I just know they're there because, well, I just know they're there, that there are a number of places that young mothers avail themselves of for prenatal care, and then for home births, and then post-birth care also. I mean, they might still have a doctor in Duluth that they see, and that, but what are the resources that already exist?
well, so
Do we
have-
know? I mean, that's the question,
Yes.
do we know?
Yes, we have Hannah Miller, who we contract through Sawtooth Mountain Clinic, who I believe the position used to be Teresa Borax, and then it's changed
Yeah.
somewhat, and so we have that. Then there is,
She's a family home visiting nurse.
thank you for the position title, that helps me. And one of the programs that Hannah is spearheading is it One Strong Mama or Strong Mamas? And it's a doula program to try to get more doulas trained. I don't think there is a coordinated doula or midwife organization. I think it's a pretty loose, it's not an official group that are doing that. It's kind of like you're saying, there are those people in the community doing it, but none of which I don't think work through Public Health Human Services.
We helped support a cohort of doulas who were recently trained through Cook County Higher Education. That, in addition to WIC peer breastfeeding, WIC primary care, these are all direct patient care roles. This role that would be increasing Kristina's hours by 10 hours is a systems level role, policy systems and environmental change, working with the health systems in Duluth, working with local businesses, which is very much within the scope of her role in workplace wellness, is how can we support parents returning to the workforce so that they have access to safely express milk at work or breastfeed at work. So this is, again, a systems level role. It's not providing direct patient education or care to parents in our community, but helping coordinate across those systems.
Questions? Thoughts? Questions?
Mr. Chair?
Yes?
I think the discussion has been really valuable, very helpful, and with that, I'd like to move to approve an increase in the hours for our public health educator.
Second.
Okay, we have a motion from Commissioner Sullivan and support from Rana. Further discussion? I heard it in.
Yes. And I would like, I mean, that motion, that this increase in hours exists only as long as the grant hours exist. Will not be in perpetuity. I mean, there'll be an evaluation, but definitely there has to be a cutoff date if it's just grant dollars, unless before those grant dollars go away, there's more, or we find that it's really important and, you know, it really has its value.
Well, I think.
I don't want it to be open-ended.
I think if Commissioner Sullivan is amiable to that, but my understanding is from our discussion is that is what happened.
That
It's
is.
that way.
That's
It's already
normal.
that way.
That's true with grants.
Standard operating procedure, right?
So then Kristina will know that when the money's gone, that her 10 hours of coordinating for it's over.
For additional hours.
Her
would be done.
additional hours are over.
And it might be more accurate to say is if the money's gone instead of when the money's gone, because this is.
Right, when the money's gone.
If the money's gone.
Yeah, you know, look for other grants. We'll be looking for
Yeah.
other different grants to support it ongoing.
If-
Is really how it would work.
If the grant ran out and there was not regional support, then we would have to have that conversation and see if we wanted to keep it going. But do you want to make any amendments to your motion?
I would just
or-
leave it as is.
Okay.
It's that way with all grants.
Okay, is there further discussion? Hearing or seeing none, all in favor?
Aye.
Aye.
Aye. Opposed?
Nay.
Motion passes 5-2.
Both ways there, that's okay.
That moves us down to the committee reports.
Chair?
Oh, I'm sorry,
Yes,
Commissioner
okay,
Storlie.
I have one comment because it pertains to public health. I just received the wonderful PowerPoint that we tried to see today. I'm concerned, I like to see things ahead of time.
Yeah.
Is it possible to have the PowerPoints in our packet so that we can review it, and if we have technical difficulties, we still have it?
Yeah, that's a great
It's
request.
just my comment.
Yeah,
Well, we can certainly aim for that going forward.
Okay.
Commissioner Storlie.
Okay, thank you.
good comment, thank you, good suggestion. As I was saying, we're on to our committee reports here, and we're running short on time, so maybe we'll try to do an abbreviated committee report. If anyone has anything pressing, please speak up, but I'll just run through the list and stop me if someone has something pressing here. First one is Active Living Steering Committee. Next one is AEOA. Nothing pressing from me on that. AHA, we deferred our meeting because there are some opportunities that ABHI are talking about, so I'll have more updates later. ARC, Child Care Solutions Subcommittee. Community Health Board, nothing. Local Advisory Council for Mental Health. Please.
One thing that we'd had a long discussion on suicide prevention services, and one thing I didn't know is that you could call 988 and just ask to talk to someone, ask for help as like a concerned person. You don't have, it doesn't have to be just, this is an imminent thing now,
Right.
we call. So that was news to me, so I think that's important for people to know.
Yeah,
That's
yeah.
available as a
support
a
line.
helpline.
Yeah, yeah. Thank
That's
you.
all.
Thank you. That's a great point. Then we got Restorative Justice. We have Council on Aging. Emergency Preparedness.
Just that we debriefed on the Emergency Preparedness Conference at our last meeting last week. And we hope to expand and have an even larger conference next year, but it was very well received, and we are glad it's back after the pandemic.
Yeah. Healthcare Planning. NACO.
I squeezed it in.
Yeah. Northeast Minnesota Office of Job Training. North Shore Collaborative, we've met, offered grants and denied one. And Public Health and Senior Services Advisory Council.
Allison did a great job in telling everything that happened at our meeting.
I will just mention that we're looking at rescheduling our July meeting as it
Oh,
falls on the
good point.
holiday. So we'll be sending out notice to members, noticing that on our website once a meeting day is posted.
No meeting on the 4th of July.
No meeting on the 4th of July.
And then down to the good of the order, which probably isn't anything pressing here, but that moves us down to adjournment. Is there a motion to adjourn?
So moved.
Is there support? We are adjourned. Thank you.
Thank you.
I don't trust them. I have a big thing.
I said then we'll have committee of the whole.
Oh.
after that, and